Thank you very much. Good morning everybody. Good morning all the audience. At the outset, let me thank Merrill Life Sciences, maybe just two. I'm here at Narayana Hospital, Bangalore, and we'll be showing a live case using a MyValve. But before that, I would like to give a talk on MyValve. Next slide, please. These are my disclosures. So as we all know, the transcatheter aortic valve journey has been fantastic, beginning in 2002 when the first valve was done by Dr. Alan Kribbier. It was a balloon expandable valve which was done retrogradely from the left atrium, left ventricle up into the aorta, and thereby setting the stage for the transcatheter valve therapies. As we all know, there are two US FDA approved valves. One is a balloon expandable valve, Edwards Sapien, which has the present generation is Sapien 3. The core valve, which has again developed and evolved into Evolute R and Evolute Pro. Next slide. These are the emerging TAVI therapies. The challenge has always been to reduce the paravalvular leak. Sapien 3 came out with an extra skirt. The Centra, direct flow, portico, engager, heart leaflet, various different valves which are there in the pipeline for the transcatheter aortic valve replacement. Next slide. Next slide, please. So the MyValve is an indigenously designed balloon expandable valve. It is a bovine pericardium. The outer frame is made of nickel cobalt alloy. The upper half of the frame has an open cell to ensure the filling of the coronary sinus. The lower half has the pericardial skirt and an outer buffing which is made of PET. It gives us more radial strength and prevents the perivalvular leak. It comes in four sizes: 20 mm, 23 mm, 26 mm and 29 mm. Next slide. Next slide, please. So, next slide. So, MyValve transcatheter heart valve device is crimped directly across a balloon, and this is inserted inside a 14 French or 16 French Python sheath. Python sheath is an expandable sheath. Somebody from the Merrill Life Sciences up there can show the sheath. The valve is crimped over a navigator balloon, and it has a proximal and distal stoppers which prevents the valve from migrating when it is being inflated. The direct crimping of the valve over the balloon makes it a little bit more simple procedure. Next procedure. Next slide, please. So the navigator balloon requires certain volume to fully inflate. 30 ml for a 29 mm valve, 23 ml for a 26 mm valve, 18 for a 23 and 12 for a 20 mm valve. Next slide. This is the Python sheath. It is a hydrophilic sheath. It is a 14 French sheath and allows entry of the 22 French or 24 French profile of the valve when it is crimped over a balloon, and the sheath expands as the valve is being advanced, and it collapses back to its normal shape once the valve is in the abdominal aorta. Next slide. The valve comes with a mammoth over the wire balloon, which is a pre-dilatation balloon. It is so in the 10 or 11 cases which I have done, this is more like a non-compliant balloon with rapid inflation, rapid deflation. Next slide, please. So this is the details about the MyValve preclinical workup. Next slide, please. So MyVal-1 is the first in-man trial which is presently ongoing. The number of patients to be enrolled are 30, and there are more than 20 Indian sites. Next slide, please. Again, it is a prospective multi-center single-arm open-label study of MyValve transcatheter heart valve and treatment of severe symptomatic native aortic stenosis. The primary objective is to assess the safety and effectiveness of MyValve transcatheter heart valve in the intermediate to high-risk symptomatic patients with severe aortic stenosis. Next slide, please. Next slide, please. So again, we'll be enrolling 30 patients all over the country, and the follow-up will be 30 days, 6 months, 1 year, and 2 to 5 years. Next slide, please. These are the various centers. Next slide. Again, the key inclusion exclusion criteria. Next slide, please. Next slide, please. The routine assessment, you do a CT scan, do an echo, measure the STS score, have a heart team meeting, enroll the patient into the trial. And I'm going to show you one example, which was case number 9, where 78-year-old gentleman, severe aortic stenosis, NYHA class 3 to 4, had severe lung disease, renal impairment, heart failure in past 2 weeks, good LV functions, and had an STS score of 8.2%. Next slide. There's the echo velocity of 4.71, mean gradient of 52, effective orifice area of 0.5 centimeters square, good LVEF. Next slide. Next slide, please. And this is the echo reading. Here you can clearly see the mean gradient is 52, the peak gradient is 89, velocity of 4.71. Next slide, please. Next slide. CT scan assessment, I mean, you already had a talk on TAVI, so I believe everybody knows this CT scan is mandatory for TAVR planning, and it is an ECG gated CT scan for the annulus measurement and a non-ECG gated aortogram to look at the peripheral vessels. Next slide, please. This valve is sized based on the area, and we look at the coronary height, sinus distances, sinotubular junction height, leaflets. Here you can see there's some calcification on the leaflet. Next slide, please. This is again the LVOT diameters. Next slide, please. So sometimes, if there is a lot of calcium at the annulus, it becomes a little of challenge for a balloon expandable valve, because if there is a calcium chunk or a calcium boulder at the annulus, and when you're doing a balloon expandable valve, this calcium can rupture the annulus if you're trying to treat a perivalvular leak or your valve is oversized, maybe something like 20% plus. Next slide, please. Again, the CT scan root assessment. Next slide. Next slide. This is a sizing chart. As I clearly stated, this valve is sized based on the area of the annulus. All these valves have their own area, and then we can calculate the percentage oversize, which is the difference between the area of the valve and the annulus divided by the area of the annulus, and it gives us a percentage oversize. Anything up till 15%, 10 to 15%, we are comfortable. If you're going up till 20% or so, then we have to look at other parameters, sinus distances, coronary height, any calcium at the annulus. Next slide, please. Optimal deployment angle we get from the CT scan definitely has reduced the amount of contrast which we were using initially to try to find our coplanar view. Next slide. So I think we bring that pigtail, shoot an aortogram, find the coplanar view, cross the valve with an Emplatz straight tip wire with your balloon dilatation. Next slide, please. So this particular patient had low coronary height. So in order to protect this one case I'm going to show you, we showed it a live case also. I apologize for a lot of disturbance which is going on right now, because we are in the middle of preparation for a live case and I'm not controlling the computer. Someone from outside the lab is controlling the computer. So what we did is, this patient had a low coronary height. His left coronary artery was only 9 mm. So we protected the coronary, you can clearly see, with a wire and a stent in there. Once we inflated. Can somebody go back to the previous slide, please? Previous slide? Yeah, I think we are going very fast. Play those slides, please. Play those slides. So we did a really minimalistic approach in this patient. What we did is we took an aortogram by keeping a pigtail in the non-coronary sinus. Then we crossed the valve, did a pre-dilatation. Because the left coronary was very low, we engaged the coronary with the XP LED 3.5 catheter. We made 2 extra holes in the catheter, wired the LV, parked our stent in LAD, wired the LAD, parked our stent in the LAD, went in ahead with the valve, crossed the valve. We pulled our catheter a little bit back into the ascending aorta, did a clockwise did a counterclock torque or clockwise torque in order to orient it towards the aortic root, took an angiogram from the guide catheter. Please play those videos. Play those videos, please. Yeah. So you can see how we're trying to take a picture from the guiding catheter. And once the position was confirmed, we went ahead and inflated the balloon expandable valve. So you could clearly, yeah, okay. I can understand some of you might be wondering why we didn't put a pigtail from the radial artery. Yes, that is one way. We could always put a pigtail from the radial artery to make sure what we are doing. Next slide, please. Next slide. So once we have confirmed that the coronaries were not occluded, we remove the wire. Next slide. And then we went in again with the guide catheter, took a picture. Previous slide, please. Previous slide. Play that aortogram. Play the aortogram. Play the slide. Okay, there's some problem with the slide. Alright, so the valve was implanted very well in the right position. We didn't have any perivalvular leak. The coronary flow was good. This is the 2D echo transthoracic. We do most of our cases as conscious sedation. The transthoracic echo shows mean gradient of 3, peak gradient of 6, velocity of 1.2, and almost no AR. Next slide, please. Next slide. Next slide. Next slide. So this is how we try to land our MyVal. We try to be 70% aortic and 30% ventricular. Next slide. So this is the summary of cases which have been done until now. We have completed 11 cases. No 30-day readmission rate, no pacemaker as of now. One patient had 2 plus AR. All of the patients, 10 of them had no to trace perivalvular leak. No mortality as of now, no stroke as of now. Next slide, please. These are the centers which have been contributing to the trial. Next slide. Again, next slide, please. So all subjects have been successfully treated with the device. No periprocedural events. 10 cases were done under conscious sedation. None of the subjects required any post-procedure pacemaker as of now. And all subjects were discharged successfully. Average hospital stay was 5 days.
Can we increase the volume, please?
No pacemaker requirement as of now. I think it's too early to comment on anything. Next slide. All I would say is the first 11 cases have successfully completed, have gone home, and 5 patients have completed 1 month follow-up. The ongoing MyVal first-in-man trial will establish the proof of concept in terms of device safety and efficacy. Next slide, please. Thank you so much.